We have had the Catalyst Opmedica system since last April, so we've had it for about 8-9 months. We've had experience on about 400 eyes to date, and I'll go ahead and talk about what we've had so far. These are my financial disclosures. I'm a consultant to Opmedica. Potential benefits of laser cataract surgery, as we've gone ahead and discussed so far, is that there's a more predictable and accurate shape of the capsulotomy with more consistent IOL capsule overlap, reduction or elimination of ultrasound phacoenergy, and fewer intraocular manipulations. When we look specifically about the Catalyst system, it's basically broken down to 4 steps. A planning step where you can go ahead and have a technician go ahead and put in all the patient information, put in parameters such as what size capsulorhexis you would like, what the nucleus density is as far as LOX 3, LOX 4. So the parameters have already been preset. Then we go ahead and engage it where we go ahead and dock on the patient with the liquid optics interface. Once that is done, then we go ahead and using the OCT imaging, we go ahead and visualize the lens and customize things based upon the ocular surface fits and then treat. So when we're going ahead and planning the procedure, we've gone ahead and listed exactly what type of grade of cataract it is, how much the posterior capsular safety margin is, and it's basically a very quick template-based system where you go ahead and can go verify all of the docking systems. Then you go ahead and engage with the liquid optics interface. And the one thing that's very nice about the liquid optics interface is that it's very gentle as far as the patient is concerned. The intraocular pressure will go up by about 13 to 15 millimeters of mercury with minimal hemorrhaging taking place. As a result, there's no corneal distortion, and it provides for a very clear optical pathway for very good imaging. And what you'll see is that because of the clear optical pathway, you have a very nice OCT image that takes place inside there. The other thing is that by going ahead and creating this liquid optics interface, you don't create any type of distortion as far as the cornea is concerned, and the potential for any type of skip lesions, and especially when you're going ahead and creating a capsulorhexis, is basically eliminated. And I think that with the new change that's taken place with the LensX system, that has also helped to go ahead and alleviate any potential issues that did exist. When we go ahead and visualize and customize the laser, what is very important is that irrespective of how you go ahead and dock on the laser, there will always be some degree of tilt that is associated with the docking procedure. When we go ahead and dock, we go ahead and take 2 images, the axial view as well as the sagittal view. And what you demonstrate right here is in this aqua blue imaging, you go ahead and demonstrate the area that we're going ahead and treating with the laser. I typically will have a 500 micron safety margin from the visualization of the posterior capsule to where we go ahead and treat. And what is really important is we can go ahead and compensate for the amount of tilt. And what you'll notice is that when we go ahead and show this tilting taking place, you'll see that based on the tilt, the margin of the treatment goes based upon the amount of tilt. So you can go ahead and adjust things accordingly based upon the surface fits right there. And there you can go ahead and demonstrate the capsulotomy as well as the lens fragmentation and the overall safety zone that's provided for. One very, very nice feature within this particular system is that there are force sensors that take place. And what's nice about the force sensors is that while you're going ahead and doing the actual imaging taking place, the force sensors demonstrate if the patient's eye is tending to move one way or the other way. And as a result of that, you can go ahead and know if the patient's creating too much force on one side or the other, you can gently kind of adjust the patient's head to try to alleviate any type of loss of suction. I've done thousands of interlace cases, and basically even though we've done that, there's always a risk as far as loss of suction. With this particular system, with the amount of force sensors that are there, I've yet to ever lose suction on any type of patient, and I feel that this is very, very important. Then you go ahead and treat the laser, and when you go ahead and treat, it's broken down into you can go ahead and first do the capsulotomy, then the lens fragmentation, corneal incisions, followed by the arcuate incision. And this lens treatment in general is very quick and comfortable for the patient. When we go ahead and use the corneal incisions like the previous slide showed it, you can go ahead and create different types of formats as far as the type of incisions that you may create. And also what we've demonstrated is with the arcuate incisions, you can go ahead and very precisely locate where those arcuate incisions are, predetermine the depth. They are much more accurate in terms of the refractive effects with this procedure. As the various laser systems have shown, when you go ahead and utilize a laser capsulotomy versus manual capsulotomy, you will have much more accurate sizing, shaping, and centration as far as the capsule centration is concerned. We've also found that we've been able to reduce the amount of ultrasound usage, and what we've found is that, based on my own data, that we've had a 70% reduction as far as the total amount of ultrasound softening that's taken place. And in general, when the lens tends to be much thicker, more like a grade 3 or grade 4, we will tend to have much more reduction as far as the amount of ultrasound usage inside there. So in general, what we find is that there's, like I said, a 70% reduction in ultrasound energy. The low suction is very comfortable as far as patients with virtually no subconjunctival hemorrhage. There's practically no capsular rents, capsular tears, or drop lenses here, which has become pretty much a non-issue overall. So when we started doing this last April, from our standpoint, our goal was basically to have a very good patient experience where it was efficient, comfortable. The lens softening would be, to me, that was probably the biggest strength of this particular system, and we wanted to try to reduce the amount of ultrasound energy. We wanted to have free-floating capsulotomies. We did not want to have any issues as far as rents or tears inside there, and we expected clear incisions. With the first 109 eyes treated with the capsulotomies, we had 108 that were free-floating. We had one that had a one tag, and there was actually a small little scar on the cornea, so that when the laser light went through, it created a little bit of a tag in that location, which we could identify. No anterior capsular tears or posterior capsular tears. Subsequent 300 cases have followed suit with no posterior capsular tears and an occasional anterior capsular tear with corneal pathology. And the subsequent 100, actually now a couple hundred eyes, have basically had very good experience as well. So in general, I feel that our experience has been very good with this particular device. It's exceeded what we expected in the sense that when we got this device on board, my biggest concern was, would we be able to have enough patients that would be able to actually proceed with this type of technology. When I go ahead and talk to our patients, I just present this as a simple choice. My goal is not to be a salesperson, but to go ahead and mention that we have choices with cataract surgery. One can go with manual cataract surgery or laser-assisted cataract surgery. What has been interesting is that there is a general gravitation of patients that want to go towards the precision as far as the laser-assisted cataract surgery. And in our clinic, we currently have about a 25 to 30% conversion rate of patients who elect to proceed with this technology. Thank you.